We are very lucky indeed to have Dr. David Claman speak to us this morning. He is a pulmonologist in San Francisco with over 34 years of experience in pulmonary medicine, critical care, allergy medicine, and sleep medicine. He is director of the Sleep Disorders Center at the University of California, San Francisco. Dr. Claman has extensive experience in lung diseases and in all sleep disorders, including sleep apnea and insomnia. He earned his medical degree from the University of Texas Southwestern Medical School. After completing medical school, he arrived at UC San Francisco and says he never left. After he completed his residency in internal medicine at UCSF, he completed a fellowship in pulmonary and critical care medicine at UCSF, followed by a fellowship in sleep medicine at Stanford. Dr. Claman has published extensively on his research, which focuses on sleep apnea and non-invasive therapy for breathing difficulties. And with that, I will turn it over to you, Dr. Claman.
Thank you, Lynn, for that kind introduction. Let me share my screen and hopefully everything will line up the way it did previously. Just let me know if that isn't working. It's a pleasure to join your group on a Sunday morning with a little bit of drizzle outside and happy, excuse me, happy Halloween to everyone. And it's nice to, be able to share some of the pieces of information that I know and some recommendations. And there were several questions that were posed to me in advance to make sure I addressed them, and hopefully they're included in the talk effectively. So sleep disorders in people over 60, yes, that includes me now too. So I'm happy to share that knowledge. All right. So I have no disclosures or conflicts in terms of the talk. And just a brief introductory slide. There's a couple of books that I would certainly recommend. Why We Breathe by Matthew Walker, who's a UC Berkeley professor, was quite good a couple of years ago. The Mystery of Sleep is also good. I've been asked recently about the book Breathe, but I haven't read it yet, so I can't include it on this list. And our sleep center is open during COVID for either in-person or video visits. The lab testing is still run out of the Mount Zion site here in San Francisco on Divisadero. And if you do end up feeling that you have a sleep problem, I'll say at the beginning, basically you should discuss your symptoms with your primary care doctor or PCP to consider getting a referral, depending on what those issues are. Sometimes it may be to our sleep center, but it could be to a neurologist or a psychologist, depending on the issues involved. Now, the outline I'm going to cover here is aging and sleep, then insomnia. I'll talk a little bit about restless leg syndrome, and then finish with obstructive sleep apnea. So in terms of general sleep, sleep over the lifespan is outlined here in this diagram. And what you can see here on the left side, this is total sleep in minutes, which of course is highest over 600 minutes when you're a newborn baby and sleep quite a lot. And then over here in terms of age, 20, 40, and 60. And what you'll see then in terms of the stages, awake in bed is this white area. The total time in bed from this line is the black line. And then REM sleep are the hatched bars here, which you can see generally stay pretty consistent as we age. REM sleep in normal health doesn't change much. Stage 2, N2 is the most common stage, and slow wave sleep is down here at the bottom, which I'll touch on in a few minutes. Now, REM sleep is generally preserved, as I just mentioned, and it's likely to be involved in memory consolidation, that it helps the mind to be able to remember things more effectively. A second comment that I'll make here is note longer hours in bed after age 60. So roughly here, if you focus on age 60, if you're still working and you're trying to constrict lots of daytime activities into a full day and evening, you don't go to bed as early. But one reason that sleep subjectively changes after age 60 is you start having more time to go to bed earlier. And even though the amount that you're sleeping doesn't change significantly, there's more time awake to add to the perception that you're not sleeping as well. So this is a common experience for people. Now, the purpose of sleep is still unknown, but one factor that I'll highlight in a couple of slides involves eliminating active metabolites that accumulate during wakefulness. And so this is something certainly important, because we all know if we don't sleep that we don't feel so hot the next day. So a little bit of a summary slide here on normal aging and sleep, and you can find a reference here if you're interested in looking at something in more detail. Sleep duration appears to be very mildly reduced as we get older, not by any dramatic amounts, a few minutes per decade, essentially. And waking up after you fall asleep, what we call wake after sleep onset, also increases a little bit. If we look at the sleep stages here, women over 65, men over 65, both still have good percentages of dreaming sleep. There's some bigger studies that have looked at this in volunteers in the population. Interestingly, though, women over 65 still have good deep sleep, or N3 sleep, a percent of around 20 if you're living on your own independently. But men over 65 have less deep sleep. The reasons for this are not known. You lucky women who are still getting your deep sleep, that's good for you. But there has been a measured decrease more noticeably in men in terms of deep sleep. And the only thing that really seems to help people sleep deeper is regular activity like exercise or even just walking. So stay active, and that helps with your deep sleep. A couple of challenges here: awakenings and difficulties with sleeping. So awakenings of 2 to 4 per night are common. And from the slide before, of course, if you're in bed for longer hours, you're going to wake up more often because you're just not as tired for sleeping deeply. So if it's normal to wake up 2 to 4 times per night, part of the challenge can be learning to fall back asleep. It's not just once at the beginning of the night, but if you get up to go to the bathroom once or twice, you have to fall back asleep each time. So difficulty falling asleep is reported in 60 to 65% of people over 65, and difficulty staying asleep, 63%, a similar percentage. And so one of the interesting parts about this in surveys is difficulty the same as insomnia? Because some people might respond and say, oh, it takes me a few minutes to fall asleep, but I'm not too worried about it. Well, you wouldn't say I have insomnia, but for someone who gets frustrated or worried about it, then difficulty can quickly translate into a symptom of insomnia because they're not sleeping as well as they would like. I will comment in terms of normal circadian rhythms that a short siesta after lunch does feel quite natural for most people. And this is because of our circadian rhythms, that after lunch, it's normal to feel more tired and drowsy. And I say short and siesta to basically say, it's accepted in many countries. There's nothing wrong with taking a siesta. A short siesta of 20 to 30 minutes around 1 or 2 in the afternoon is unlikely to worsen your sleep the next night. But a longer nap after dinner in particular is going to definitely cause insomnia. And we'll talk about sleep hygiene in a few slides. So one of the newer concepts in sleep, this is a citation from 2015, is on the glymphatic system. So glymphatic is sort of a hybrid word of the glial cells. Glial cells are brain cells, and the lymphatics. So if you think about the lymphatic system here, just as an introduction, the lymphatic system in our body is designed to fight infection. It helps with immunity, absorb fat products that we eat in our diet, but it also maintains fluid balance and helps eliminate cellular waste so that as our cells are active, they build up waste byproducts that need to be eliminated, and the lymphatic system works for that. But the glial cells in the brain do not have a lymphatic system. So what's been recently described is this glymphatic, so a glial lymphatic system essentially. And the glymphatic system is inactive during wakefulness so that our brains can be alert, awake, but it takes a lot of metabolic energy. And so you develop some of these waste byproducts. When we fall asleep, it certainly makes sense that if the glymphatic system becomes active, more fluid is pulled out of the cells to help metabolize anything that's been used during the day, then it can eliminate cellular waste and keep our brains functioning effectively. So again, the glymphatic system is a concept that has been newly developed over the past few years. And as I mentioned a couple of slides ago, REM sleep appears to aid in memory consolidation. So we think that that's one helpful part of it. I think probably the deep slow wave sleep that I mentioned is part of when the glymphatic system is more active. All right, so that's what I was going to cover about normal sleep and aging. I'm going to shift gears a little bit and go into different causes of insomnia, because insomnia is the most common sleep complaint in society. It can be problems either falling asleep at sleep onset or staying asleep during the night, what we call sleep maintenance, or waking up early at 3 or 4 in the morning and not being able to get back to sleep. And this goes back to what I said a couple of slides ago. As we get older, it's common to have difficulties either falling asleep or staying asleep. And for many people, then they feel like, this is more of a real medical sleep problem, and then it would become labeled as insomnia. So we have depression, anxiety, medical illnesses, drugs, psychophysiological insomnia, and then poor sleep hygiene or poor sleeping habits. I just want to highlight these areas. So probably a quarter of people with chronic insomnia have problems with depression and anxiety. If it's depression or anxiety, then a good person to help with that would be a psychiatrist or a psychologist and explore therapy and medications for that. Medical illnesses certainly become more common as we get older. So medical illnesses could be pain issues, whether it was arthritis, hip pain, back pain, headaches, things like that. Getting up to urinate at night, which is, of course, quite common as we get older. Postnasal drip and acid reflux can interrupt breathing and cause coughing, any breathing issue from heart or lung diseases. So you might imagine if you think that you have a medical problem that's affecting your sleep, go to your primary care provider. They're going to be the best person to address these medical interruptions to try and figure out what to do. Now, the two drugs that I want to highlight are caffeine and alcohol, because these have different effects on sleeping, and it's useful to keep track of these. So caffeine would normally be implicated in keeping you awake at bedtime, so delaying your sleep onset. And most people don't realize that caffeine can stay in your system for 8 or more hours, so that having coffee, tea, or a diet soda at even 4 or 5 in the afternoon can easily impact falling asleep at 10 or 11. If you drink coffee after dinner and fall right asleep, no big deal. But if you have insomnia, I often will tell people don't have caffeine after 12 noon, so that there's a good 9 to 12 hours from that point to get it out of your system. So caffeine makes it hard to fall asleep. Alcohol, in contrast, tends to cause middle of the night awakenings. So if you drink alcohol near bedtime, and near bedtime would be within 3 hours, then it can help you feel drowsy and fall asleep. But then you might wake up 2 or 3 hours later when the alcohol's wearing off, and then have trouble falling back to sleep in the middle of the night. So we generally say just be careful about both quantity and also timing. Now, psychophysiological insomnia is about anxiety, where people start to worry about their sleeping. And when you worry, your body tenses up, and then that tension activates your mind to be more awake. So the psycho part of it is the psychological reaction with anxiety, and physiologic is the body tension that develops. These two feed off of each other, and that keeps people awake at night. So the more, in layman's terms, the more you worry about the sleeping, the worse it can get. But it's hard to avoid worrying about sleeping as you get more frustrated. And then I have a slide about poor sleep hygiene, but 2 simple examples are napping after dinner, which of course then it's hard to fall asleep. Or if you're tired and you go to bed too early, of course you're going to be waking up more often during the night. We like people to keep regular sleep schedules. So for sleep hygiene, just to cover those topics in a little more detail, and here's a book if anyone wants to read it that's paperback or available in the library. Keep a regular schedule in terms of your timing of bedtime and wake up time. Don't go to bed too early if you're tired. Keep the bedroom quiet and comfortable. A relaxation technique for 10 to 20 minutes before bed, whether it's deep breathing, listening to music, or doing a meditation app, can be helpful. You can repeat it during the night if needed, but if you're really relaxed at bedtime, hopefully that will carry through to the rest of the night schedule. And then be active, regular exercise, as I mentioned, to help with the slow wave sleep. If you have insomnia, don't nap. But I still think a short nap at that siesta hour is okay. And it's okay to nap if you're sleep deprived, because if you're sleep deprived, then the napping can be a good thing. Don't lie in bed feeling worried or anxious. This tension is what keeps you awake. And this is where being relaxed and calm and peaceful is important. Don't lie awake in bed for lengthy periods. That just adds to the frustration. If it's 45 minutes to an hour, get up and go read in a different room if you can. Do a crossword puzzle or something else that'll slow your mind down. And then again, as I mentioned before, avoid alcohol for 3 hours and caffeine for at least 8 hours before going to bed. But there's a self-help book if you're interested, but there's a lot of sleep hygiene resources available online. So if we talk about medications, I just wanted to comment, there have been some small studies. This was a publication in a psychiatry journal back in 2004 about tapering doses of benzodiazepines. And so there are different options to taper sleep aids. Motivated patients can make progress, because these were subjects who enrolled in a research study. They were taking on average about 10 milligrams of Valium per night. And there were 3 arms to this study. One group had cognitive behavioral therapy only. One group just had a scheduled taper of medications that they were going to reduce the dosage per week. and the third group had a combination. And the upshot of it, as you can see here, is all three groups were able to reduce their medicines down to basically 10 milligrams of Valium per week, as opposed to 10 milligrams per night, whether it was with a medication taper, cognitive behavioral therapy, or CBT, or a combination. So this is a good concept for people who don't think that they can make progress. But one of the big new initiatives or pushes that we have in sleep medicine is to do cognitive behavioral therapy, or CBTI, to really help with sleeping. And part of the reason I like to emphasize CBT for insomnia, or CBTI, is that if I say, hygiene, follow these rules, don't break the rules, or you're a bad person, just following rules doesn't tend to help people reframe and relearn how to sleep better. And CBTI is more of a multimodality approach that looks at this from different angles. I listed 3 different options for being able to go through CBTI, 2 here at UCSF, group classes with Dr. Mason, and then the neuropsychology clinic that has individual sessions. There's a private clinic in town that we work with also. The CBTI can easily cost over $500 and sometimes more than that, because often seeing a psychologist is either not covered by insurance or it's only partially covered, but it can still be very worthwhile. Now, CBTI includes sleep restriction, spending less hours in bed, which increases sleep drive, stimulus control, don't go to bed just to watch TV or do your checkbook. It really is only when you're sleepy and feel like you're going to fall asleep. A relaxation technique at bedtime, being mindful of yourself, and so that you want to be non-judgmental when you're mindful. But then if you feel that you're getting worried or frustrated, it's like, oh, I'm getting worried, I'm getting frustrated. So you're aware of your reaction, but not in a critical way. You want to be non-judgmental. And then the sleep hygiene elements of this. To pause here on sleep restriction, when you spend less time in bed, it increases your drive to sleep better. And so one way to think about this is if you have a bad night of insomnia and you only sleep 3 or 4 hours, you can relax a little bit about the next night and say, oh, good, I'm going to sleep better because I have a big dose of sleep deprivation. If you have a bad night, there's probably less need to take extra medication the night that you go to bed the next night. But you want to stay up to your usual bedtime and not go to bed early. It's just a useful way of thinking about it. And here's a nice slide, excuse me, from a 2015 research publication where the authors looked at CBTI and the effect on both insomnia and depression. And so they enrolled people who were on antidepressants. The control group just got self-help reading materials, but the cognitive behavioral sessions were every 2 weeks. And the upper graph is the insomnia severity, and the lower graph is depression scores. And what you can see in the gray lines, which was the active CBTI group, excuse me, the insomnia clearly improved quite a bit more than the self-help group. There was a little improvement in the self-help group, as often is seen in these studies. That's why you need a randomized trial. But interestingly, with no change in antidepressant medicines, the depression scores dropped quite a bit in concert with improved insomnia. And even in the control group, this was true a little bit, but clearly the CBTI group got the best improvement in both insomnia and depression. So I think this is a useful lesson that CBT as an approach can be very helpful for insomnia, and there may be other benefits for other symptoms. Now, this is a busy slide, but medications are sometimes necessary. I think we all know that, but I would always frame this by saying they should always be combined with behavioral treatments. So you're being thoughtful about how you approach things. So on the prescription side, we have hypnotics, sedatives, sedating antidepressants, and the new orexin receptor antagonists. And on the more herbal or over-the-counter side, we have antihistamines, melatonin, valerian, and cannabidiol or CBD, a cannabis product. So looking at these, hypnotics are probably the most common prescription for insomnia. They're short-acting and they're most useful for sleep onset insomnia. They do not have anti-anxiety benefits, and zolpidem or Ambien is the most common one. For our age group, it would be a 5 milligram dose. That would be the highest recommended dosage. Now, sedatives are more long-acting benzodiazepines, and they do help with anxiety, but they have a longer half-life. And because of that, if you take them several times a day, they can be more physically habit-forming. The hypnotics don't have any physical habit-forming potential. Another common approach is sedating antidepressants. Trazodone and mirtazapine are common ones that have longer acting duration. Trazodone is probably the most common one of these, and so they're good for sleep maintenance insomnia, but they can cause hangover drowsiness because of this long duration of action. And then the newer medicines, these orexin receptor antagonists, suvorexant and lemborexant, I rarely prescribe these. Their half-life is over 12 hours for each one. But there are patients who struggle with all these other options, and I have had patients who've tried these, and sometimes they work, but it's still usually, if you come back to behavioral approaches, you're going to get some benefit from that, which is what I showed on the prior slide. Now, the third other medicine that's fairly common is diphenhydramine, which is a sedating antidepressant. That's what's in Benadryl and many of the Tylenol PM and Advil PM products. Most patients who use diphenhydramine say, well, I'm a little groggy in the morning and I'm a little dried out, but I slept better, so I don't mind. Because with all these medicines, you're trying to balance side effects versus some therapeutic benefit. And melatonin is also quite common. It's short acting. I think it's a reasonable medicine to try. There are no formal studies on it for insomnia, but it does help for falling asleep at the beginning of the night. Valerian is popular. It's an herbal remedy. It has few side effects. It doesn't have a dramatic therapeutic benefit, but it does help some people. And then cannabidiol and some of the cannabis products, there's minimal research for insomnia. I've had patients say it helped them. I've had patients say it left them groggy the next morning. It's just a question of whether you want to try an approach like that. Cannabis products, there's better evidence for using them in chronic pain. But this is a busy summary slide for a lot of those different medication issues. But I would always come back to behavioral approaches as a way of trying to avoid being on medication if possible, or higher doses of medicines if you're using. All right. So let me take a sip of water and then I'll shift gears to restless legs. So restless leg syndrome is something that we see in the sleep clinic. Probably a lot of people are underdiagnosed with restless leg syndrome because not as many people are aware that it can be a clinical issue. But it's a clinical diagnosis based on awake symptoms. We don't need a sleep study to make this diagnosis, because what patients will say is they've got sort of a hard to describe leg discomfort. Their legs are uncomfortable. It's distressing a little bit, but it makes it hard to lie still because as soon as you move your legs, the discomfort goes away. And so the typical symptom in restless legs is sleep onset insomnia, not because of an active mind, but because the legs are uncomfortable and you have to keep moving them. So restless leg is characterized by the urge to move the legs induced by rest. So when you lie down in bed, the discomfort is relieved by movement, and it has a circadian rhythm to it, so it's worse at night. Although patients will often tell me that their symptoms feel worse when they're on a plane trip and their legs are just more noticeable to them. Restless legs can run in families. It's autosomal dominant when it does. Iron deficiency, neuropathy, renal failure can bring on symptoms as well. And there is a website here. This is a patient advocacy website, rls.org, if you wanted more information. And so here's a summary publication about treatment. But typically we would look at iron deficiency by testing ferritin. If the ferritin was below 75, which is technically normal, but below what we think as the optimal range, then we will give iron supplementation with vitamin C to try to get the ferritin to a higher level. And this can improve symptoms, especially if the ferritin is at a low level. Symptoms can get worse with antidepressants, caffeine, and alcohol, so just be aware of those potential interactions. The simplest treatment for restless legs is to stretch before bed, consider a short bath if that helps soothe the nerves. But some patients do end up benefiting from medications, and the two most common classes of medicines are dopaminergic agents like pramipexole or ropinirole. Those are commonly used for Parkinson's. This is a different condition that's not related to Parkinson's, but the medications can still be helpful. And then gabapentin or Neurontin is another common medication that is used. There's other options, but these are usually what we would consider as a bedtime medication to see if it helped the restless symptoms get reduced and make it easier to fall asleep when you lay down. And then the last area that I wanted to cover was to talk about obstructive sleep apnea and some of the treatment options here. I'm going to fall into my lingo and call it OSA because I think that's easier. So obstructive sleep apnea or OSA. And what we can see here in terms of the idealized version from this figure is that with an apnea, if you look at airflow is normally, up and down in terms of pulling in air and breathing it out, but then the airflow gets blocked. And so there's no airflow, which is the apnea. And you can see the muscles from the ribs and abdomen trying to breathe. So there's respiratory effort. That's how we know it's obstructive. And at the end of this apnea, the brain wakes up and has what we call an EEG arousal to basically interrupt the sleeping. There's a drop in the oxygen after the apnea finishes, and it's the arousals and the drop in oxygen that make it obvious what's happened when we do a sleep study. Now, with a hypopnea, which is shallow breathing, airflow isn't completely blocked, but it's much reduced. There's breathing effort, there's the EEG arousal, and the oxygen desaturation. So we look at both apneas and hypopneas. And so the key definition for OSA is the apnea-hypopnea index here. If anyone's interested in more information, there's a recent review in the New England Journal of Medicine. Apneas are for 10 seconds. Hypopneas also have to be reduced airflow for 10 seconds. And then we calculate this apnea-hypopnea index, which is the number of apneas and hypopneas combined per hour of sleeping, so per hour. A normal index would be under 5 episodes per hour. So you can have 20 or 30 apneas in a night and still be in the normal range. Because people do have a little bit of breathing irregularity in different sleep stages, but a mild apnea would be 5 to 14 episodes per hour. And this can cause symptoms, but not as consistently as more severe apnea. Moderate 15 to 29 episodes per hour, and severe would be 30 or more episodes per hour. So we would calculate this index to decide how worried to be and how aggressive to be in terms of treatment. Now, one of my favorite questionnaires for OSA, obstructive sleep apnea, is the Stop Bang questionnaire developed in anesthesia, which is 8 questions to see if it can predict risk. This is a sensitive questionnaire to suggest testing, but it's not specific. You still need a follow-up test to see. So the stop part is snoring, being tired or fatigued, observed apneas, and high blood pressure. So pressure, that's stop, snoring, tired, observed apnea, hypertension. And then bang is BMI over 35. This is body mass index, and over 30 is considered by the numbers to be obesity. Age over 50, neck size above 17 for men, 16 for women, but most women are too smart to wear tight-fitting collars. It's only us men that do such silly things. And then male gender. So it's easy to see in our older age group. My wife says I snore. I believe her. Sometimes I'm tired. I like to think it's work, of course. I am over 50 and I'm a man. So you could argue that my score is 3 or 4. I've been tested and don't have sleep apnea, but that's an example. I think as we get older, many of us are likely to be in the medium risk score, at least to think about by this questionnaire. So part of the reason to worry about OSA is that it could contribute to cardiovascular disease. Hypertension has the strongest association with OSA in the literature. If you take a single medicine and your blood pressure is controlled, then we would be probably less worried, but there's still an association. But if you have drug-resistant hypertension, so you're on 3 different medications, there's a much higher likelihood that you'll have coexisting OSA. Heart failure, so CHF is congestive heart failure, can be worsened by untreated sleep apnea. So that's something to keep track of if you develop that problem. And then atrial fibrillation, which is the most common arrhythmia in the general population, 1 to 2% in the general population. It's about 5% in OSA patients. So again, there's an association. And one smaller study from Mayo Clinic showed that if you were using CPAP to treat apnea, you were more likely to stay in sinus rhythm after cardioversion. But if you did not use CPAP, then you had a higher recurrence rate. So there's a relationship here. And these are 3 examples of cardiovascular complications. So a brief comment here about home testing, which has gotten more common. It's been in use for more than 25 years in various sleep centers, including ours, but was only approved by Medicare about a decade ago. But it's certainly more common now, and especially with the pandemic. The limitation here is that since the AHI is based on the number of hours of sleeping, we make an estimate of the sleep hours, so the results may not be quite as accurate. This is more important probably in milder cases than in more severe cases. If a home test shows that you have sleep apnea, we would commonly then recommend a trial of auto-adjusting CPAP as the next step, but it depends on different factors. And home testing can also be useful to see if an oral appliance or surgery were helpful. So I wanted to go over some of the treatment options here. For anyone who's been evaluated in a sleep center for snoring or apnea, these are going to be familiar ideas. The 4 conservative treatments for sleep apnea are weight loss, because 10% of weight loss can reduce the apnea by about a quarter, avoiding alcohol for 3 or more hours, that pops up again, postural training, so only sleeping on the side as opposed to on the back, and keeping your nose open, so treating allergies or congestion can certainly help. Seasonal allergies are quite common here in Northern California for many people. If you don't have them, I'm happy for you. I certainly get grass allergies in the spring. And so it's good just to be aware of this as a 4th arm of the 4 conservative treatments: weight loss, avoid alcohol, side sleeping, and the nasal patency. Now, CPAP is still our gold standard, and we use data analysis, and I'll show a picture of that in a few slides. You have to choose a comfortable mask. Nasal mask or nasal pillows are certainly more common than the full face mask. And auto CPAP or APAP is another version here, and we're getting fonder of that as well. Oral appliances for mild to moderate sleep apnea can be fairly effective. They're less useful for severe apnea, but if a patient can't use CPAP, I'm always going to explore this as a possibility. And then there's surgery, whether it's on the nose, the palate, where it's about 40 to 50% successful for apnea, tongue, mandibular advancement, and bariatric surgery. We do have a program at UCSF. Bariatric surgery is usually more considered if the BMI is over 40, so you're in the morbidly obese range. Now, here's an example of an anti-snore device. So here's the website, and I'm not advocating for this, it's just an example. But the idea of the anti-snore shirt or belt is that you've got these bumper pads that you wear along your back. And then if you were going to roll to your back, this would make it too uncomfortable, and you would wear this for 1 to 3 months to make sure you learned to be a side sleeper. If you have a sleeping partner and they can nudge you politely to roll over, that could work. You could put pillows behind your back also. But this particular anti-snore belt runs around $100 or so, but there's quite a few different websites available. So this is just one example. And here's a picture of what an oral appliance might look like. And it would have an upper plate and a lower plate for the upper and lower teeth with an adjustable mechanism, because what the oral appliance is doing is pulling the jaw forward to pull the tongue a little bit away from the back of the throat. Interestingly, these appliances are quite medically appropriate for mild to moderate apnea, but they're a lot more expensive potentially than the CPAP. The CPAP gets good coverage through medical insurance, and it's a standard approach. These appliances fitted by dentists cost more, and they're not always covered by insurance, or at best they're partially covered. So if you look into getting an oral appliance, just realize there'll be more of an out-of-pocket expense. And then I was going to briefly touch on the new surgery that's been developed, just so people can see that this exists. It's stimulating the hypoglossal nerve on the right side of the neck to stimulate that muscle. You might hear the term Inspire as the brand name of this particular device. And it involves an implantable nerve stimulator under the skin, but below the collarbone. And part of it is a sensing lead that goes under the skin between the ribs, and then a pacing lead that comes up here with a little cuff around the hypoglossal nerve. So this gets turned on at night with a little controller device. When the sensing lead detects muscle effort for breathing, then the stimulation lead will give a gentle voltage shock to the hypoglossal nerve to get the muscles to open the airway up. So it's phasic stimulation only at night. And of course, we have to keep the voltage stimulation level below the pain threshold. It's not approved for mild apnea, so only moderate to severe apnea. And you can't be too heavy because that's a contraindication as well. So the BMI has to be below 32 to 34. But at 12 months, you can see that the apnea would be, the AHI number would be reduced from around 60 down to around 7. So for those people who go through this, it can work well. We think since the battery's only turned on at night that it would last 8 to 10 years before needing replacement, but no one's had the device that long yet to know when that would happen. But there's select patients might be interested in this. Now with CPAP, I like to show a picture of nasal pillows. Still, it takes a bit of getting used to wear nasal pillows, but your mouth is normally uncovered. This is an older style mask where the tubing comes off out front, but there are newer styles where the tubing comes off the top of the head. And with CPAP, which stands for continuous positive airway pressure, it's site non-specific. So this graph outlines this, that when we're awake and breathing normally and our muscles are active, then we have negative pressure in the airway, and that pulls air into the lungs down here. But when we fall asleep and the muscles relax, that's where, if you have apnea, the airway can collapse shut. And so the positive airway pressure from the CPAP nasal pillows or the CPAP nasal mask puts air pressure in here. So in some ways, sleep apnea is like a flat tire while you're sleeping. You have to stop and fix it. And with positive airway pressure, it's like having an inflated tire so you can keep breathing and keep resting. One of the biggest predictors of CPAP compliance is whether you have severe, moderate, or mild apnea. And to me, this makes intuitive sense that severe patients are more likely to have symptoms. They have the highest compliance rate, up to 90%. Moderate apnea falls off down here to maybe 75%. And mild apnea here has the lowest compliance, although this is going out to 10 or 12 years or more in some of these studies. But this still is a nice breakdown. A lot of patients with mild apnea just don't have a lot of symptoms, and the CPAP can be a cumbersome treatment, of course. Here's the data download that I mentioned. So it's a standard part of practice now to review the usage data. And the Medicare requirement that's been adapted by insurances is during the 90-day trial period, that initial starting of therapy, 70% of the nights need to be over 4 hours. So this is a nice graph. You can see all these green bars that are all over 4 hours. So this is one of my perfect patients. 100% of use are over 4 hours. The average use is 8.5 hours a night. And the events per hour is down below 5 into the normal range. So this is just a nice example, but this is the kind of information that we can get from the CPAP devices. So conclusions, and then hopefully this will give us time for questions. Prioritize your sleep with behavioral treatments for better quality of life. If insomnia is a problem, it's optimally treated with CBT and behavioral treatments. I listed some options for that. Hopefully medicines would either be unnecessary or only occasionally needed, but there's a range of medication options as we reviewed. Restless leg syndrome is a clinical diagnosis based on symptoms, and OSA is more of a sleep study diagnosis where we need a diagnostic study. OSA can cause both sleepiness and cardiovascular issues. CPAP therapy remains the best therapy, and compliance is improving now that we have the data management tool, but mild OSA patients still have the lowest success rate or compliance with CPAP, And that's why I wanted to review the anti-snore shirt, the oral appliances, and some of those other considerations. I'll stop sharing my screen at this point. That's all my prepared remarks. I'm happy to go back to the slides if there's a question that relates to a specific slide. But thank you all for listening, and hopefully that's a good amount of information that's both relevant and some of it even new. I think most people have never heard of the glymphatic circulation, which I like to include. Thank you for listening.
Dr. Gutton, thank you very much. That was extraordinary. Reminder, if you want to ask a question, put it in the chat. If you know how to do it, you can raise your hand. And if you just get frustrated, you can always unmute yourself and try to ask it. Jeff, do you have any questions at this point you want to pass on?
Nothing on the chat. Nothing on the chat. Personally, I had a quick question. Dr. Claman, if you could go back to the medication slide, you mentioned Benadryl. Of all of the words on that slide, that's the only word that was familiar to me. And I'm wondering if you can go through, there's some of the clinical names for these medications. And I'm wondering if you could mention the better well-known names. I think people might be able to relate to that a little better.
I do want to point out one thing here, and that is that this often comes up. I will spend with a patient during a visit, I'll spend 15 to 20 minutes talking about behavioral treatments. And then the patient will say to me, but doctor, what about these 3 medicines that I want to try? So I'm always amused that people come back to the medicines, but I can understand that that's the more common perception of what would work.
It's not that I'm drawn to the medications, it's that you mention these different classes of things, and those classes will mean more to me if you mention how I might have heard of them.
Sure, exactly. Anyway, but it's interesting. So hypnotics are the short-acting medicines. So zolpidem is Ambien. Many people have heard of Ambien for jet lag or short-term insomnia. S-zopiclone is Lunesta. It's it's a slightly longer acting hypnotic, but it doesn't have active metabolites. The sedatives here, lorazepam is Ativan, and a similar drug, clonazepam, goes by the drug name Klonopin. And the third one that's a real big anti-anxiety medicine is alprazolam, which goes by Xanax. So there's a number of different types of drugs here. Lorazepam, clonazepam, alprazolam, or Ativan, Klonopin, and Xanax. Trazodone is generally a generic medication. I think it was, I'm not even sure I remember a trade name for it. It's just generic. Mirtazapine here goes by the name Remeron. That's a common sedating antidepressant. I think if you have depression, Remeron is more common. Trazodone has less of a mood elevating benefit. So it's usually more just for insomnia. And then suvorexant is called Belsomra. That's a newer type of sleep aid. Lemborexant, I think is called Dayvigo. I've still never prescribed it, but I do know about it from some of the studies. And then diphenhydramine is Benadryl, and then these others are what they are.
We have a specific question. We have a specific question on Calm Forte. Does that ring a bell to you?
It does. Whoever's asking, if you can tell us what's in it, I think Calm Forte has a little bit of melatonin in it, 1 or 3 milligrams probably, and maybe some calcium or magnesium.
It does appear to have a milligram of melatonin.
And that's a lot of these over-the-counter ones do incorporate melatonin. And melatonin is short acting. I don't think it has a lot of downside. And plenty of people do take melatonin fairly often.
Can you please show the CBT tasks and goals again?
So this was the slide about improving insomnia and depression. But the different modalities that are used in CBT are sleep restrictions, so spending less hours in bed to increase sleep drive, only being in bed when you're sleepy and feeling relaxed, not when you're going to be reading or watching TV for lengthy periods. Making sure that you're physically and mentally relaxed with deep breathing, a short shower, something like that. Mindfulness, so being non-judgmental and aware of your mental and physical reactions, and then the sleep hygiene guidelines.
Okay. Juanita, you had a question. I've unmuted you.
Yes, I'm one of the non-compliant people on the CPAP.
You have lots of company, that's okay.
Yes, and a lot of it is because I'm very restless. I move around, you know, and I have trouble staying asleep, falling asleep, and that I found the machine really cumbersome. Is there anything on the horizon to do something similar, but not so cumbersome? I mean, it seems like an almost medieval device in some ways to have. So I was just wondering what's being researched in that area, because it seems like everyone's happy with that for the way it works, but it's hard to use it for many of us.
Well, first, let me say, Juanita, you've got a lot of company, and a lot of people are unhappy with CPAP. They're unhappy either because, of course, psychologically, they don't want to have to use it. A common scenario is that people wear the CPAP because their doctor or told them to, or their spouse wanted them to, so the snoring went away. But many people just don't feel better from using the CPAP. And you know, if I ask you to take a blood pressure pill once a day in the morning that takes 20 seconds, that's pretty simple. But if I ask you to, you know, put a mask on for 7 or 8 hours during the night, that's a lot of treatment to be able to get through, especially if it doesn't noticeably improve how you feel. So I think these are the reasons that the CPAP can be a challenge. I think that although the machines are smaller and quieter than they used to be, it's still a machine and an air compressor. And I like to think that nasal pillows or small masks are easier, but they still take getting used to, there's no question. I think on the in terms of the general treatment options here, there isn't anything magically different than the CPAP that I know of on the horizon. The appliances are problematic in some ways because they can work, but they can be expensive. But that's probably the most common alternative for us as we get older, because most people do not want surgery. So that's why I focus on, you know, CPAP and appliances as non-surgical therapies. I guess 2 other points I would make. There's been some recent interest in trying medications, and there have been some pilot studies that have looked at using a combination of 2 different medicines to help with sleep apnea. The problems with medications are, number one, that they don't have a dramatic effect, at least not so far. And then number 2 is you need one medicine to help in non-REM sleep, and you need a second medicine to help in REM sleep, because the neurotransmitter activities are different in those 2 sleep stages. So this is still something that's being investigated, and I don't think is going to come to fruition in the near future, but we'll see. The third comment I guess I would make here is, if you can't use CPAP and the appliances are either unaffordable or unappealing, many people just live with trying to do postural training, maybe getting a wedge pillow that puts them up 5 or 7 inches. And they just stay with the conservative treatments. There is a role for that. I'm more comfortable with avoiding CPAP if the sleep apnea is really mild. When it gets to be moderate to severe as a doctor, that's less comfortable for me to not treat, but some patients still decide that they don't want to be on active treatment. Is that a helpful answer?
Yeah, it is. I was just curious, for me, it's not the mask, it's the tube. And, as I move, I go, where is it? And so I just keep thinking, well, surely there's some way you could bypass that.
Well, let's
a small
pivot.
motor that could be on the top of your head or something. I don't know. It's an engineering problem, really.
Well, let me pivot here and just show you. I'll just pull up a picture of this particular mask. There's a lot of two of the big companies now are putting masks where the tube comes off the top of your head. So you can see that there's nothing on the front of your face, and it's a swivel top so that it can pivot. The difference with this, though, is that the tubes on the sides are how the air pressure gets into the mask. As that's comfortable, then it's easier to have the tube move around. But at any rate, the companies are aware that they need to come up with more and better options.
Okay, very quickly, I've got three questions I'd like to address because I don't want to lose you. You put the Philips CPAP up just then. There was a poster that that particular CPAP is on a recall. Is that anything that we should be particularly worried about?
So the masks themselves are not recalled. So the Philips DreamStation mask or DreamWear mask is fine. I didn't include this in the slides, but it's a good question. If you have a ResMed machine like the AirSense 10, there are no problems. But the more common the more common Philips mask, the DreamStation, has been recalled. The public information, which they have not updated back in June, is that about 0.03% of the DreamStation machines were having some problem with foam degradation, either that you'd see foam particles or dust or smell an odor. But that meant that more than 99% of those devices were still okay. It's hard to know whether there's a bigger issue, but because they haven't published any follow-up analysis of the 99% that weren't causing obvious problems. So they've recalled the DreamStations. So if you have a DreamStation, you should have gotten a letter, or you should go online with Philips and register your device. A lot of patients with severe apnea are benefiting from the CPAP and are not noticing problems with their DreamStation CPAP machines. So I've had a lot of patients stay on CPAP while they're waiting for a replacement machine. But if you have mild apnea and you're not really sure whether it's helping, then there may be more of a risk-benefit analysis that favors going off the CPAP while you're waiting for the replacement. So it's a work in progress, and I'm frustrated that we don't have more specific information.
Could you go back to the slide that had the level of REM sleep and deep sleep over your age group?
Yeah.
Okay, we had two questions, one of which was, as you think about it, which is more important between the two, REM sleep and deep sleep?
They're both important. I wouldn't prioritize one over the other because I think they perform different functions and they're valuable that way. As we get older, and if you have health issues and you're on multiple medications, there can be different reasons to have lower percentages. But I think they're both important. That's why I recommended exercise to help with the deep sleep. And there isn't any specific treatment or intervention that affects dreaming sleep percentages.
Okay, and looking at the declines, there are many of us here who are over 75. And so do we expect to see these numbers continue to decline as we age?
In the study in men, which was the study of men with osteoporotic fractures, a number of these subjects were in their 70s and 80s. So I don't think that that's going to change a lot, but we don't have any current updated information. But I think that's probably representative for being in your 70s and 80s at this point.
Okay, and if I were a man over 65 and I was looking at deep sleep of 10%, should I be concerned with that being not enough?
No, because I think it appears from this study to be fairly normal for the population. So I don't think it's any cause for alarm. I just put this in as a descriptive, as a descriptor from some of the data that we know from research projects.
Okay.
I'm probably in that group where I'm only a couple of years away and I'm not too concerned.
Okay. If you basically sleep 5 or 6 hours and then wake up at 3 or 4 in the morning and have trouble getting back to sleep, do you have any particular recommendations for someone with that situation?
So it's pretty common, and as I like to say here, part of the challenge is that waking up is very common, whether it's 1, 2, or 4 times, and kind of being really peaceful and relaxed about it is really necessary to falling back asleep. This is where, if we come back to the sleep hygiene guidelines, when you wake up, don't get worried or frustrated. If you do, that's going to keep you more awake. I would lay in bed for a good half an hour to see if you can start to feel sleepy and doze off, and make sure you don't have too many blankets or not enough blankets. And then if you need to do a relaxation technique, deep breathing or something, that's great. But often what I recommend to patients is, if it's more than half an hour, get up out of bed and go do puzzles or read a book in a different room. You'll likely get tired and then be able to doze back off. I do have patients where I go through this exercise with them, and they'll say, but if I get up, I feel worse the next morning. If that's true for you, some patients say, well, I lay there from 3 a.m. until 6 a.m. and I think I'm awake the whole time. The odds are that you're dozing off lightly from time to time. It's not satisfying sleep, but you're still likely getting some rest. Because if you get up and feel worse, partly because you're awake, that does imply that you're getting some rest if you just lay there in the dark. And I would come back to this point about bedtime. Sometimes you're so tired by 8 or 8:30 that you go to bed. If you sleep from 9 to 3 and you've gotten 6 hours, part of the challenge is that it may be because you're going to bed so early. And one approach to that is to try and stay up until 9 or 10 so that you push the sleep hours back just a little bit. So those are some of the strategies you can consider.
Okay, I've got 3 backed up questions before we close this thing out. Lynn, you wanted to add something if you want to unmute yourself.
Yes, can you hear me?
Yes.
Okay, so regarding taking Benadryl products, are there long-term side effects? You mentioned short-term effects of feeling drowsy the next day and dry mouth, but if someone were to take a product containing diphenhydramine repeatedly, is there a problem with long-term dependence or long-term side effects? I've heard, excuse me, but I've also heard that it may contribute to the development of dementia over time. Do you have experience with that?
So if we come back to this, now I regret putting this slide in, but I knew I needed to here. So with all of these, so first off, diphenhydramine is never habit forming in a physical sense, but like many medications, if you take Benadryl, you do get a little bit of sedation. There's a pharmacologic effect, and you also relax. Oh, I took a Benadryl, I can relax now. And that's part of the placebo effect. That's a good thing about many medications. But it's psychologically habit forming because you get used to both that pharmacologic benefit and the placebo effect. But what you want to try and do is get the placebo effect with behavioral treatments. Now, the bigger studies, so there's no long-term harm. Benadryl gets out of your system after 6 hours or so. So it's not going to be something that builds up as a problem. The challenge with this issue about cognitive problems or dementia, we often get asked about because there was one study in particular that was a big cancer registry that followed patients for 10 to 15 years. And what was found was that if you had insomnia problems and took a sleep aid, it wasn't always known what the sleep aid was, that was a risk factor for developing cognitive problems. Those studies don't look at cause and effect. They only look at associations. If you had sleep difficulties and took a sleep aid, there was a risk. We don't know whether that risk was from other illnesses that you had, from the insomnia, from the sleep aid, whatever that might be. But that's where this concern about zolpidem or Ambien and lorazepam or Ativan has come up with. But none of these agents have been individually studied to look at that association or that risk, and there's no cause and effect that's been proven. So the way I tend to frame it for patients is I think that if you have a lot of insomnia, then there's probably a lot of therapeutic benefit to taking medications. And I think the risk of using sleep aids is low. If you decide that the number one priority of your existence is to avoid anything that might contribute to cognitive problems, and then you could say, well, that's my number one priority, so I'm going to avoid all of these things. Then you land back with behavioral treatments, which is what I think should be the first approach anyway. Does that make sense?
Yes, thank you.
Okay, I've got 2 more questions. We'll try to keep them short. There was a question on here about the books that were referenced. This presentation is being recorded and will be on our website later today. So let's not try and answer that here. There's a question about something called COQ10. And somebody who has said, I understand it is good for restless leg when taking statins. Do you have any information to provide?
I have no information. I don't know of any specific sleep therapy that involves coenzyme Q or CoQ10. And I don't know of it as a treatment for restless legs. So I can't comment on that.
Okay, last question. We'll go back to CPAP in your head. One of the problems we have is we are located in a fire zone at the north end of Sonoma Valley. We've actually had 2 fires that have impinged on our community. As a result of that, we both have power outages and we also have evacuation situations. We have, in an emergency preparedness sense, one of our recommendations is you want to be able to hear an emergency come up on your phone or your NOAA radio. So you have to be careful about having something that interferes with your hearing during an emergency situation. So if you are using a CPAP machine, is it safe to turn it off if there is such an emergency? Or should you be evacuating and finding a place where you can be safe?
I guess a couple of comments. One is, in the vast majority of people with sleep apnea, it's fine to be off the CPAP for a few hours or a few nights. It's going to cause some symptoms if you're not on it, but it's not life-threatening in any way. So if somebody's on a ventilator because they have, say, ALS and they must have the ventilator, that's very different. But the vast majority of people on CPAP, if the power goes out, you'll wake up, you just take your mask off. And then, you know, hopefully, I mean, with some of these fires, it's a big problem, of course, because you could lose power for days. But often power outages are short term and you just suffer through that night, but hopefully the power comes back on and you can use it the next day. So there are the two big companies do sell batteries that you can use that'll get you through typically 12 to 20 hours, so that they might get you through up to 2 or 3 nights if you got a battery to go with it, whether it was a branded battery or a generic battery. I think for the average person, it's not such an urgent issue that you should evacuate just to have power. That would be sort of my thought about it. But it's a tricky question because people will get very distressed, especially with severe apnea. And then just for having you feel better and cope with the stress, there could be circumstances where that helps.
Well, I cannot thank you much on behalf of the Sunday Symposium for joining us today. And with that, we are going to close up and remind you next week, we have Mark Randall, who will be talking about Afghanistan, what happened. And that will be in Berger as well as on Zoom. Thank you again, Dr. Claman.
My pleasure. I hope you all learned a lot.
We
did.
did. Outstanding presentation. Thank you.
You're welcome.